Everyone happy with the minutes? Yep. I think all the action points are picked up in the meeting, and so David, can we move on to your report, please?
Yeah, thanks. Good morning, everybody. Thank you, David. So it's a brief report, but there's a number of updates because at the time of drafting the report, there were things that we were waiting for which have now happened, like committee debates on the Care Bill, and the Select Committee have now published this morning or last night their report. So just going through the report, I was asking, but subsequently I'm advised that I don't need the board's approval because it's a matter which is delegated to me anyway through the delegations, that Andrea from the 1st of February begins to take responsibility for the operational decision making about registration. So we begin a phased handover of operational decisions, and so rather than approve that, David, I wonder whether I could ask the board to note that. In relation to the preference process, we've now begun the process where inspectors and inspection managers begin to state their preference for the role that they'd like to progress to from the 1st of April. So these are generic inspectors and generic managers, and they're expressing a preference as whether they want to go and work in the directorate that Mike is leading, the directorate that Andrea's leading, and the directorate that Steve's leading, i.e. primary medical services, healthcare and hospitals, or adult social care. That process is underway now. The window's open, I think, for about a 3-week period where people just make a simple selection and set that out. As of last Friday, I think there were just short of about 200 people that had already expressed the preference. There's over 1,000 altogether that will express the preference of inspectors and inspection managers. When that closes at the end of this month, what we'll know is what people's preferences are, and from that we'll then be able to confirm the time at which people will transfer to that post. We've got operational responsibilities from the 1st of April, so if we've got an asymmetry in where we've got our colleagues, then we might need to phase the transfer of people so we can actually do today's business. But it will also allow us to be absolutely clear about 2 things. Firstly, how we go and recruit additional staff up to the numbers that we set out in our planning. And secondly, what the issues are in terms of both inducting new staff that will be coming in, those new staff that we'll appoint, but also for people that are now moving into specialist areas, specialist directorates, I'm not sure if this is the right phrase, but what the conversion training will be for them. So how are people developed in the methodologies that need to be. So at the end of January, we'll have, rather than general numbers, precise numbers on which we can work in relation to the way that that goes forward. So I hope that updates the board in relation to that process. Sorry, I probably missed one thing from that. Hilary and Andrew Larter and Eileen's colleagues in HR have spent a lot of time working with both the staff forum and the trade unions in relation to this. Indeed, I think there have been weekly meetings with the trade unions, and the consequence of that investment of time in those relationships means that actually there's very clear visibility for those organisations about this, and it feels that the conversation is very constructive and positive conversation. Indeed, I met the trade unions was it the week before last, and they were very positive about the nature of engagement, which is a good thing in terms of the spirit in which this is moving forward. Onto the Care Bill, we've in this brief note set out some of the issues in relation to the Care Bill, in relation to fit and proper people, the issues around enforcement action, but the note also referred to yesterday the committee session of the Care Bill actually considered a number of issues and recommendations in relation to our role in relation to adult social care, and particularly the market oversight component of that. There was a pretty broad debate about the role that we've been asked to take, which is providing the market oversight, the financial oversight of adult social care providers. and a number of amendments were tabled by Her Majesty's opposition in relation to that, with the intention of giving us stronger powers and with the intention of helping us to do the job that we're asked to do. You will be aware that there's been previous discussions about whether this is an expansion of our role, a broadening of our role, which takes us beyond what we should be focusing on. During the consultation, I think the Department of Health, the government settled that issue by saying it's either CQC or a monitor. The decision was it was to come to CQC. I'll speak in a second, David, about the Health Select Committee, and again it's one of the issues that Health Select Committee raise again in their report as to whether this is something that we should continue with or whether it's something that monitor should oversee. Needless to say, in relation to this, we continue to do the work. There's a report that Paul will present later in the agenda, so I'll not go into the details of this, but as I say, the Care Bill spent some time on this yesterday, and we'll come back to it next week, where I think they'll actually have further discussion on exactly these issues. Fourth item in the report is in relation to the statutory duty of candour, which again is related to the Care Bill. The board may recall that the Secretary of State asked Norman Williams, the President of the Royal College of Surgeons, and now Sir David Dalton, the Chief Executive of the Royal Salford Hospital, to do some further work on really definitions of the threshold at which the duty of candour should operate. This was really trying to get round the issue of whether the issue that we discussed at our last board meeting, which was really about whether our interpretation and that of Robert Francis, that we should consider where serious harm has been committed or affected on people, that should be the threshold. The beauty of having taken a board discussion to that evidence is that we were able to represent not personal views, but the views of the board. David Dalton in particular was very influenced by some work which has gone on in Australia, which is consistent with a much more expansive view of the duty of candour. And we were able to share that view with them, and they'll take that. They're seeing a range of people during January, and then we'll give advice to the Secretary of State consistent with what he asked them to do. So it'll inform this work. The fifth item is...
Can we just maybe just hold it there? I mean, there's the financial oversight issue around social care, obviously important. There's the fit and proper person, and there's the commissioning of social care, whether we should do a thematic review or look at or have some responsibility for looking at the commissioning process. Anyone like to proffer any views on any of those issues, or do you think we've got it about right? I mean, can I just make a couple of points then? I mean, one is, I think the financial oversight, we'll talk later on, Andrew probably will part that from that. On the fit and proper persons test, I mean, one of the issues is whether or not existing people, we should look at existing people rather than just new registration people. And whether we would do that through our inspection process rather than need to change anything in the law or anything, I think is an issue. I mean, Mike, for example, when you're looking at hospitals, whether they're well led, you are looking at the board, you're meeting with the non-executive directors and the chairman, aren't you, anyway?
Yes, we always meet with the chairman, the chief executive, at least one of the non-executives, the medical director, nursing director, chief operating officer. That's a bare minimum. Yeah. Usually other sort of senior managers like the complaints manager as well. And we can... depending on circumstances, we can talk to others as we wish. I think we also, with foundation trusts, are now meeting with the governors as well.
Yeah. And with adult social care, again, when we do our new inspection regime, we'll again under the well-led domain, we'll be looking at the manager, obviously, the qualities of the manager. So maybe
yes.
Yeah.
Absolutely.
Okay, and then Louise.
I mean, I think we have to be absolutely, clear about what we expect and have a process around it. But I mean, one thing that sort of clinicians say is that, if we do anything wrong, we've got the GMC or the NMC or the Health Professions Council. And I know this isn't regulation, but I wonder if there's kind of some sort of learning, if you like, or something that we can sort of learn from regulators to sort of, you know, and I appreciate it's not exactly the same, but I think it would be, you know, it would give us quite a good sort of context. Yeah.
Just on the fit and proper person, that might it hasn't. We haven't had very long to read the Health Select Committee report, which has been out for a couple of hours. But my understanding on a brief reading was that it makes reference to this issue in relation to chairs and chief executives of organisations. And clearly it's unhappy with the current position that as to who is covered by that test. Could you just say a word about that? I must say I hadn't appreciated that they were excluded.
I think existing people are excluded, but anyone who's coming up to be registered for the first time, it will cover them. It doesn't cover people who are already in post. Is that correct?
I can take this.
Oh, Paul. Sorry, go on, Paul.
So when the evidence went to the Health Select Committee, the policy was still being debated between DH and ourselves and Monitor, and there was a holding position because Monitor also have a fit and proper person test, so they wanted to consider whether they needed to do the role for chairs. Since I think the position has moved on, certainly in terms of the policy discussions, and the view is the fit and proper person test would simply cover everyone, including the chairs. But we need to confirm that with the department, but that's certainly our view. So it's just a question of timing when the evidence was given to HSC.
Just a little bit more on the extension of powers into local authority commissioning. Is that to do with market oversight role of local authorities, or is it to do with the management of the quality of or the commissioning quality of?
So can I just do the fit and proper piece? I think the etiology for some of this debate, I think there's two strands for it. One is Southern Cross, and I think there's also a bit which is from Robert Francis, but there's also a line from the issues around Castlebeck and the home in Bristol. Oh God, I've forgotten the name of it. Winterbourne View, where the staff were prosecuted at Winterbourne View, but there was no reach into the people that sat in the operating company above Winterbourne View in relation to any responsibility they may or may not had. So the fit and proper person test is a way of actually reaching into, not, as Kay was saying, those that are professionally accountable already to the college, you know, the people that hold their registration, but actually is allowing a reach. So that's what I think the intention is. In relation to Jennifer's point, I think this comes directly from the concerns exercised by providers that sometimes the quality of what they do is affected by the way that their services are commissioned. So if we take a view about the inappropriateness of 15-minute visits in domiciliary care, but it's 15 minutes visits which are being commissioned by the local authority, then they're saying, well, who will hold the local authority to account for the fact that they're commissioning care, which is either not at the right price or can't be done at a quality. And Leonard Cheshire, earlier in the summer, refused to go for some contracts because they didn't feel they could actually deliver the right quality of care at that price and the specification that had come through. And I think they've continued to pressure and raise this question with government. So I think this is the government's response in relation to if there's concern around the way that local authorities are commissioning care, then we have this power under Section 48 to actually do a review of commissioning of local authorities. So that's what this is about.
I'm just thinking about the read across to health. So we don't currently have those powers. I mean, we don't want to get into assessing commissioning either of CCGs or indeed of NHS England, I guess. And our role there is pretty well circumscribed. And is that right?
Well, so if you look at who's commissioning care homes, then actually there's a significant proportion of CCGs commissioning care homes for continuing health care that's in nursing care homes with nursing. And the nursing element for many individuals in care homes with nursing is actually paid by CCGs. And in some parts of the country, the majority of commissioning of care in care homes is by individuals who are self-funders. If you go to some of the southern counties, for instance, then by far and away the majority of care home residents will be self-funders. So there is a really important issue to be sorted about whether the leverage on the quality of local authority, of what is commissioned, can just be exercised by holding local authorities to account for what they do. Section 48, though, is a very broad-based power which isn't restrictive of whether we can actually look at the way that services are commissioned by health or social care. But effectively, the momentum behind this particular discussion is in relation to local authority commissioning.
Would it be helpful at the next meeting if we just did a summary of what our Section 48 powers are? Because we did get Deloitte to do a report, I think before I came here, it must be a year ago. So should we just bring that back? Because it might be quite interesting to do that.
Yeah, I think if we could somehow, at some appropriate point, just thrash out what we think about commissioning, both CCG and NHS England and our role there and the logic of our role.
Okay, well, we'll do that for the next meeting, Dave, if we can. Anna?
Thanks. So I was a bit confused about this paragraph and trying to kind of work out exactly what it meant. And I was reflecting on the conversation we had before, which I think was particularly about the fact that what the original proposition allowed us to do was to register people in a prospective way, but not to reflect on people who are already on trust boards. And I understood this to be something which would allow us actually to be, as it were, not retrospective, but in a situation where we thought there were fit and proper questions for people who had been on the board before this change, then we could require them to be removed by the trust. So I thought this was potentially quite powerful, because it means we're looking at the whole set of trust board members or board members, not just those who joined most recently. But could you confirm or deny? And I guess the second thing is just on Kay's point about the GMC. So we've had a bit of discussion about how the fit and proper persons tests might work, but I mean the GMC or the professional regulators is certainly one model, but of course the professional regulators' fitness to practice responsibilities are only apply where there's already been an issue raised about the fitness of someone to operate. So it's a very reactive process to individuals who've been substantially taken through a process already and then ended up with their professional regulator. Whereas the other model that we heard a little bit about last night at the FSA is of a very proactive, positive approval process where actually people are called to interview before a decision is made as to whether or not they're fit and proper persons. So there's kind of a huge difference between those two models, and I think it's important that we look at them all in our thinking about how we apply this.
The first point, Anna made, can you clarify that, Paul? Because I think I'm getting a bit muddled now as well.
No. So there are two bits to the law. The fit and proper person test that's coming in looks backwards. So the chair of the provider signs off that they're happy with the new director, and we check whether we're also happy. But the separate point about whether there's somebody who's already on the board is covered by a different bit of the law. We can impose a condition of registration for any employee at all that we don't think they're appropriate for the job that they're doing. So we can cover that anyway.
Be a different standard, potentially, would it? Is it different?
Absolutely to be determined. So on the overall fit and proper person test for directors, we'll have to see what the regulations that DH actually put out say, and they're consulting in the next few weeks on that. But my impression is that on both cases there'll be quite a lot of latitude to set what the appropriate standard is.
David, I mean, as with many things, the devil is always in the detail of these. And I want to make it clear I'm strongly in favour of a fit and proper person test and applying that properly, but there does need to be due process. The consequence of our declaring that somebody is not a fit and proper person is that they lose their employment or part of their employment. That has legal consequences for them. And it's important that we are able to demonstrate that when we take those decisions, we have taken them objectively and against a given set of criteria, however loose or tight the process is. And that's why I think it's important that before this is activated, there is an appropriate decision about how it should be undertaken, and we're satisfied with that process.
Picks up your point about whether it's an FCA approach or a GMC approach. So can we bring that back when these later on? Thank you. David, you want to carry on then? Item 5.
Yeah. At midnight last night, the Select Committee published their report of the accountability hearing with CQC. This was the meeting that took place last October. The press release that they issued was along the lines of CQC finally heading in the right direction. Did everybody hear that? Okay. So this was the press release of the report that was published at midnight last night, saying that we're heading in the right direction. It's a full report. Lewis has already said that it takes some time to go through and consider carefully. There's over 40 pages of it, and behind that headline, there's quite a lot of detail of where progress has been made and where further progress needs to be made, as David, you and I outlined at the meeting. And then there are a number of comments that the committee are making from their perspective, not least the one that I've just referred to, which is about whether the market oversight for adult social care is appropriately located with us, or whether, as they're recommending, DH should give further consideration to that. Notwithstanding that, I think it's good for the organisation to receive this report, positive for the organisation to receive a report. I think it represents a lot of hard work by colleagues around the table, but also by other staff right through the organisation in relation to the changes that we've taken. And also, I think, an awful lot of work by staff in the organisation with stakeholders, but a lot of work by stakeholders by themselves in relation to the work that we're doing. And I think that's reflected in, so I was particularly grateful in relation to that work. The issue of fit and proper persons, which has just been discussed, is one of the issues they touch on in the report. We've now got a couple of weeks or so to actually draft up a formal response that we'll send in to the Select Committee, which means we can give consideration to some of the points that are being raised. I'm not going to try and present the detail of it, David. I think it's this was a skill report. I think it will be good progress made, more to be done, but the direction of travel is a good one, and I think there's some optimistic phrases in here as well as some good challenges as well. So I'd want to strike the right balance. I think it would be absolutely wrong to be self-congratulatory in any way, and I think we should use it as a further springboard or platform to push on to the next phase. We've got a very busy and challenging year in front of us in terms of making the changes, and I think this will give us some good pointers and good milestones along the way, and certainly I expect the Select Committee to raise all these issues with us when we appear in front of them again in the autumn of this year for account. So perhaps if I just leave that there, David. The one more thing then, I'll just finish and then that's me done. Eileen joins us, and this is week 2 for Eileen as Director of Corporate Services, so it's good to now complete that senior team. As I walked into this room, Paul Elliott, Dr. Paul Elliott, who's joining Mike's team as the Deputy Chief Inspector for Mental Health, begins his first day, and the report also identifies that Ellen Armistead, who's currently the Chief Executive of the Lincolnshire Community Health Trust, a nurse by professional qualification, and Professor Ted Baker, who's currently at the Oxford University Hospitals as Medical Director and Deputy Chief Exec, will also complete Mike's team as alongside Andrea Gordon, who's one of our regional directors, and that's 4 Deputy Chief Inspectors in place for Mike. Negotiations around Ted arriving, we hope we inspect the Oxford in February, so we hope he can join us after that. Conversations are ongoing with Ellen and her organisation about when she can join us. So that team's there. Andrea and myself interview for adult social care in early February, and Steve and Andrea and myself do the primary medical services appointments. So we're optimistic that we can continue to get those senior appointments made and build those teams. So we've got appointments made during February. When we get the people, we'll be subject to negotiation about leases. People have been fantastic, I have to say, in terms of flexible release, giving us people for 3 days to go on inspections and inductions, etc. So again, good spirit from people, but they're an impressive group of 4 people to go and work with, Mike, by any stretch of the imagination. So we actually continue to be able to recruit high quality people, and I'm very optimistic we'll do that the same on primary medical services and adult social care as well. So that's me. Thanks.
Any general points for David on his report? Yeah.
Just a quick one, just going back to the annual accountability report. And, you know, whilst I don't think, I think we're right not to sort of congratulate ourselves. I think we can acknowledge that actually a lot has been achieved because a lot needed doing. And I think, I think it's appropriate to sort of pay tribute to the leadership and the hard work of staff. Yes, there's a lot to do, we all know that, but turning it round to get in the right direction is actually quite a considerable achievement. So, I think we could have a little pat on the back.
Thanks, Ken. Maybe in your letter to colleagues on Friday, you'll obviously mention this, won't you? Yeah. Lewis?
Just make one brief one. I think Keir's made an important point about the staff. When Hilary and I were having coffee this morning, a member of the canteen staff said to us that they'd heard on the news that CQC was doing well. And that is quite an important thing for staff to hear, because this is an organisation which has been through quite a turbulent period, and for people to realise that the benefits have been noticed, I think is important. I mean, the report itself from the Health Select Committee is quite I mean, they don't do praise in any major way, and it's quite a restrained, I think commendably restrained report. It's supportive rather than full of praise, I would say. But can I just mention to you, in the board, something I mentioned in private a short time ago, David, which is that that the reporting of the report on the BBC is saying that that the regulator has yet to win public confidence, according to a highly critical report by a committee of MPs. So you can only assume that that was recycled from a previous news story, because it's nothing to do with what the report today says. And I'm just assuming that somebody in our press office will do whatever is necessary to... I mean, it's a serious point in a way, because people who don't read the full story will only see that as the headline, and that is not at all what the Health Select Committee has said.
Thanks, Lewis. Paul, will you make sure that Chris is on that? Yeah. Okay, thanks. Good, thanks very much. Thank you. Mike, you're getting an oral update.
Thank you, Chair. Yes. And part of the reason for doing an oral update is that things are moving extremely fast at the moment in the Hospitals Directorate. Just echo David's comments about the welcome news that we have appointed 4 Deputy Chief Inspectors, and that Andrea Gordon is already working in that role, and that Paul Lelliott has started today. So that's extremely good news. First of all, if I take the acute hospitals programme, the 18 trusts that were in Wave 1, we've now undertaken site visits at all of them. We've published 13 of the 18 reports. There's obviously a lag phase between the inspection and the report being written, factual accuracy test, and then being published. I think one of the things about the group that's been published since we last met is that it includes some extremely large trusts. We hadn't done any of those before, and indeed the Keogh review didn't do any of those because they just happened not to have the high mortality. So places like Barts Health and Heart of England Foundation Trust, these are trusts having between 1,500 and 1,900 beds, multiple sites, multiple A&E departments. These are challenging, and we will need to reflect on how best to do that. But I think we have been able to do that. And In terms of the remaining 5, they're going through the reporting phase now. The quality summits will be held in early February, and what I would propose to do is, once we've got all 18, I think it will be worth bringing together an overview report, both on what it tells us about our methodology, and I'll come on to that in a minute, but also what some preliminary findings are that if you look across the trusts. So I think in terms of the process so far, all 3 phases of the programme, that's the pre-inspection planning, the inspection itself and the reporting phase, they're all working reasonably well, but I would be the first to acknowledge that all 3 could be improved. And we are generally getting positive feedback from trusts, including one trust that said it was the best free consultancy they had ever had. But so I think it's going down reasonably well with the trusts. The data that we gather before going on site is all important. We can improve on the presentation of that data, particularly if we arrange it around the 8 core services that we are inspecting, as well as what is clearly at trust level. That will help the teams when they're on site to focus on the data and then to use the data better in their reports. I think we also recognise the need to engage earlier with the trusts that we are inspecting, and for the team leader who's going to be doing that inspection to go to the trust and actually plan out the inspection so we can really see what services they are providing and know how much time we ought to be devoting to different things, but also what experts we may need for the visit. And along with that, we can do more analysis before we ever get on site, and the more we do of that, the better we will use our time on site. And indeed, on top of that, there is more training to be done, both of our own staff in the new methodology, but also of external people, whether those are experts by experience or clinical experts. And we have started what, for the time being at least, we're calling a conversion training program for our own staff, and that is now underway. So I think they will be better prepared when they get on site. And I think one of the big changes really is emphasising the fact that we're looking for what's good as well as what's not good, and that is quite a change, but equally we then need to train people in knowing what good might look like, and we therefore need to be able to define that. So it's a complex number of steps. The inspection phase, I think we are finding that the large teams are valuable, but I don't think we necessarily need them to be enormous. That comes back to the issue of how do you do these very big trusts. What we're tending to do is to break them down into 5 sub-teams looking at different core services. So A&E is always one team, the medical care is one team, surgery and critical care joined together, maternity and paediatrics joined together, and usually end-of-life care and also the outpatients, because that works best for time. We've now moved it so that the presentation from the trust comes on at the end of our training and planning day, day 0. That has the advantage that the team have started to hear from the trust themselves what the context is, but we're also encouraging trusts to do 2 things. First of all, to tell us what they're proud of, but secondly, to tell us what they see as the challenges, and to be open about it. And I think this is a point we need to emphasise to them. If we find things they haven't been open about, that is not good in terms of their leadership. So it's they should be telling us about what they know of the problems. Again, we're now scheduling the focus groups with staff earlier in the inspection process and the public listening event, because we can use that material then better to inform the rest of the inspection. While we're on site, we can always look at the out-of-hours services because we're there, and it's a good cost-effective use of people's time to go back and see what the evening handover is like, or for example. There are still huge challenges in running these inspections. The greatest challenge is in standardisation. trying not to make this a tick box exercise where there are 200 things we will always tick off, but at the same time standardising so that we are being consistent across the different hospitals. And we're learning that as we go, which is one of the reasons why Wave 1 was a developmental wave in itself. The reporting stage, again, we are learning. I think the biggest message, which perhaps isn't surprising, is the better you've done the preparation phase, the better you've done the inspection phase, the better your report will be. And it's at that stage that we realise any deficiencies that we've had in our processes at the earlier stage. What we're trying to do is to build up from the individual core services to a location or a site, such as Whipps Cross Hospital or Newham Hospital within Barts Health, and then up to a report at the trust level. If you do a really big trust like Barts Health, which is on 6 sites, the total number of pages of the report is 246. But I think that is actually useful when it is from a patient and public perspective. They want to know what a particular service at Newham Hospital is like. So we're still learning on that, but I think we're getting there. We've now had 3 batches of quality summits for each of the groups. Because they run simultaneously, I've only been able to attend 3. Interestingly, I've attended one where the trust had very few problems to sort out, one where there were quite a number of problems and we asked for a number of compliance actions, and one that we have actually put into special measures. And you won't be surprised to hear that the tone of those quality summits is quite different depending on the circumstances. But we now have the presentation by CQC, response by the trust, and then the action planning session, which clearly depends on what the outcome of the inspection has been. Just finishing off on the acute side, we have now started our second wave, and we had site visits at 3 last week, and there's 1 in progress at the moment. So that's underway, and wave 2 in terms of acutes, it's a total of 19 trusts that will be done at this side of Easter. I think I mentioned at the last meeting that in terms of what we find on these things is that we are finding a range of quality, and that persists, as not surprisingly now that we've increased the number. There's a range of quality between trusts, but interestingly, importantly, within trusts, you know, where some services may be good and some less good within a trust, and even within an individual service. So medical care may be good on a dozen wards, but not good on 1 or 2 wards. And I think that does show the specificity of the inspection process. Some of you will have seen that I did an interview with the Independent at the beginning of the year. I just want to reiterate that what we have seen in all 18 sites is fantastic caring and compassion from staff and commitment from staff. I think that is true at every single one that we have been to. Doesn't mean there aren't problems, but the caring is very definitely alive and well. I think where on those individual wards people are completely worn down, that may be a different matter, but it's not the generality. Moving on from acute hospitals, I think the next really good news is that we have started our first wave of mental health and community service inspections just this week. In the community services, the Central Essex Community Service, which is run by a provider called Provide, a social enterprise, that started, or the inspection started yesterday, and I was able to join that. Clearly too early to give you any views, apart from the fact that the process does seem to be able to be adapted from acute to the community side. There are differences. Inevitably there are differences, and there should be differences. But what we are doing, for example, there is testing out phoning with their permission recently discharged patients, but taking a random sample of recently discharged patients from community hospitals and asking them about their experience there. We are also joining district nurses going into people's homes and asking them about that. But working with at each level of the community trust. And on basis of one day, but one day only, I would say that the process looks as if it will work. In terms of mental health, we have started in Coventry and Warwickshire this week. Paul Lelliott, as the Deputy Chief Inspector, will be going there tomorrow to join the inspection, and I will be going there tomorrow evening for Friday to see how the inspection concludes. So I can't tell you anything about that yet, but at least it's underway. And I think that's really where we are at the moment on the hospitals programme.
Thanks very much, Mike. Lewis.
Thanks, Mike. One of the advantages of having your overall responsibility, including mental health, is that mental health can be rated alongside, if you see what I mean, the rating of acute hospitals, so that there is a slight danger in this process that mental health, which has been historically neglected, is then judged by a different standard, which is the mental health standard, and the fact that a lot of the facilities are poorer than you would find in acute trusts is then missed. And so I just want to emphasise the importance of that, so that that the inspection teams are sufficiently aware that they are not just judging whether this is a good service for mental health. And to take the obvious example, the physical environment in mental health, which is arguably more important than it is in other parts of the health service for people's recovery, that needs to be judged by the same standard as you'd expect in an acute cardiac unit or something like that.
Lewis, I agree with you, basically. So I think the issue is how we get that comparability, and I think there are several ways in which we can do it. We may well have some heads of inspection who will cross and do some mental health, some acute inspections. That would get some comparability. I think we will also have some inspectors who wish to do a combination. And what we're saying in the whole process of transfer into the new directorates is that we will try and accommodate. So those who want to be highly specialist in hospitals or mental health will try to accommodate them. But those who want to work across that sector, we will also try and encourage that. And I think it will be very valuable. And personally, the fact that I will be going out and looking at mental health trusts alongside acute trusts and indeed alongside community trusts. So I think I and the Deputy Chief Inspectors will, to a certain extent, cross over. I'm expecting Paul Lelliott to take largely a role with mental health, but I think there will be some crossover that we can achieve.
Thanks, Mike. Just two questions. On Wave 1, was there a substantial difference between the methods used on Hospital 1 compared to Hospital 18? I'm just thinking forward to our subsequent conversation we'll have about rating later. That's question one. Yeah. And question two, in your work, can you remind me, when you look at community, if community services are somehow lacking because of a poor interaction with acutes, that's your domain, is that right?
So have there been substantial differences? Not really substantial differences. I think we are improving our methodology, and it's the standardization bit of it. It is about getting clarity within our 5 key questions: safe, effective, caring, responsive, well-led, what it is that people should be looking for and what good looks like within each of those. And we have been developing this as we go along. By default, we had to. And also, we are learning. So we're learning, for example, if I take end-of-life care, one of the things that we are always looking at is whether do not attempt resuscitation forms are filled in correctly, and whether, if it's been filled in initially by a junior doctor, has it been countersigned by a consultant, which is clearly important in terms of is this patient really dying, and therefore is whatever is being done appropriate. I don't think it had necessarily occurred to us at the start to standardise how many of these forms we should look at as we go across the hospital. Is failing to fill in one form enough to make something requires improvement, or should we be looking at least 20? Now, those are the sorts of things that, frankly, only arise as we go through the process, and so we are then able to come back and standardise, and we will get more and more standardised on that, I think, as we go on. I think it's one of the reasons why we chose not to do ratings in wave one as the standard, because we knew that was difficult. Can I say that Hospital A overall has better quality than Hospital Z? Yes, I can, but we need to be able to defend our ratings across the board, as we'll discuss later. The handoff, I think handoffs are going to be important across the board. So it's acute to community, community to primary care. We need to be asking the questions about integration in every single inspection we do, and that will include primary care and adult social care. So, but it's trying to formulate the best questions that test that. And so, what is the link, say, between the acute stroke service at a hospital and the stroke rehabilitation service at the community hospital, as we were observing yesterday. In fact, in that case, very good integration. So I think but it's at every step. Wherever we are, we need to be asking about the integration, both with primary or community, and in our questioning, and that is in our key lines of inquiry. But we need to make sure we are doing it in a consistent manner.
Thanks, Mike. I think one of the things I was thinking of, here we are, the first board of the new year, and what are the risks that loom over the year, as against the ones that we've packaged away last year. And it seems to me one of the risks that you've been mentioning is that we're going to have to construct, as the year develops, a production line which thrums away, churning out things that up till now we've been doing as small groups. And so you mentioned about standardisation, and that how we standardise something that's been crafted is going to be the issue. And I think one of the risks is we fail to standardise, and everything then becomes incredibly expensive, and you are doing 100 hours a week, because in a sense you think about your involvement, you can't be involved in a production line the way which you can in small numbers. And the second is we standardise in a way which squishes out all of the things that are real and reproduces the model of the past. And it's not inevitable that there's a whole world between those two. But I think the thing that is that I think we're going to need some real discussion, as you were starting with us, about what is ticking boxes and what isn't ticking boxes. I think ticking boxes have got a very bad press, by the way. I think ticking boxes can achieve quite a lot. So I think as an issue, just thinking to back to forward to the board in July. The numbers that will be turning off the production line then, your relationship with them, our relationship with them, is of a different order than it is at the moment, let alone thousands and thousands and thousands and thousands. And so how we construct that relationship over the year, I think we just need to, we need to be aware of. The change in gear is a change in form.
Can we reflect on that, Paul? I mean, it is critically important, clearly. Rather than give an instant reply, I think it's something we need to dwell on a bit. Yeah, thank you.
Just on this, Mike and I met Kieran Walsh a couple of weeks ago, and Kieran's doing the evaluation. And we expect to get from him in February an interim report. So it's very much about what the first wave has generated in terms of learning. I mean, Mike's touched on some of the points, but in an interesting way, and without using the phrase standardisation, he talked about how you move from intuition into a more industrial scale. So that might be the platform for some further reflection, just to make that point, because we've asked if Kieran will bring it forward in a way that will allow that report to come to this board meeting in February. So it won't be the final evaluation, but it does raise some important questions, and we'll get the final one in May when he's looked at waves 1 and waves 2.
Thanks, Mike. Yeah, I've got a comment and a question. The comment is, you know, all the reports are kind of coming out and they're in the public domain, but I'm not sure that we're sort of good at sort of communicating what's next, what happens as a result of the reports, because things are happening. But I think the public don't necessarily know that. You know, if there's a quality summit or special measures. I mean, maybe the special measures is known, but you know, as far as the public are concerned, there's a report in the press, and if it's good, you know, fine. But if there are kind of you're going to have a baby and you've kind of criticised the maternity unit, you know, people want to know, you know, what's being done about it. And I know it's not just us, you know, it's not up to us, but I think it's about communicating that something's being done and that we're going to re-inspect at a certain point. So it's probably a communication issue, but it's an important one for the public. The other thing is, I have raised this before, but I'm still not entirely clear, and that's about how we're going to inspect services for learning disabled people. Are they going to be part of Wave 2, or are they going to be part of Wave 3, or are they... I'm not quite sure how it's going to fit in, because it's... In some ways it's small, but it is quite specialist, and we, you know, people can be very vulnerable. But I'm still not clear in my mind whether that's happening now as part of Wave 2, or whether it's going to be a sort of third sort of thing later on. So.
In response to your what next after an inspection, I mean, clearly it does depend on what we've found, and I think it will depend on what the rating is. You know, if the rating has been outstanding, I suspect the answer is it's a celebration. And if overall it's good, there will still be things that the hospital will want to tackle, and we will have pointed those out, but they will presumably be relatively minor. It's when it's clearly overall in the future, when we declare that somewhere is requiring improvement or inadequate, or a service is in those categories, that action is most important. At the Quality Summit, we CQC present an overview of the findings. The Trust is invited to respond to that, and then the third part of the meeting, particularly if it's going to be in the requires improvement or inadequate category, is led by either Monitor or the TDA. But it will always lead to an action plan. It may not have an action plan that day, clearly. So we're not usually in a position to say what the action plan will be when we publish a report. But we do, alongside the reports, of course, still have the compliance actions and warning notices, and where we say the Trust must improve, that actually always equates to either a compliance action or a warning notice, and we have been issuing those in parallel with our full reports. And I think that those things probably show the specifics that a trust needs to get on with rapidly. Yeah. But that may be a number of specifics. But alongside that, we may also be saying, you know, there's cultural development that's needed within the trust. That's clearly a longer term thing, but it doesn't mean it's any less important. I think we will make those immediate actions absolutely clear.
I mean, that's my point. I kind of know what happens, but I'm not sure. It's about sort of making sure that the public know what's happening if we can.
And I think in our press notices that we issue at the same time as our reports, we are trying to make that clear. But if we can improve on that, we will. Learning disabilities, it is sort of joint responsibility depending on what sort of learning disability facility we are talking about. Where they are attached to and part of a mental health trust, we will be doing that, but we're not doing that in this wave. But I don't know if Andrea wants to comment on.
I'll pick up the issue about learning disability services from a social care point of view in my report.
Okay, we're running behind time again already, so Anna, can you make it fairly quickly, please?
Sorry, so just 2 quick points. One relating to Paul's about standardisation. So we've talked before about the importance of quality assurance and the process that we adopt for that. So not depending so much on individual inspectors being in the right place or sort of being in several types of inspection, but actually a process which gives us assurance across the piece. And I think this is actually quite important in terms of Lewis's point about the relationship between mental health and acute services, for instance, because that quality assurance process is part of the way in which we can make sure there's some read across between the different sectors. So if we have different quality assurance processes for every type of institution, I think it would be problematic. This is one of the ways we can look at quality across the piece, is have a much more singular quality assurance process. And we know we need to come back to that. The second thing is just about this communications issue. So I do think there is an issue. Kay's absolutely right about what happens when the inspectors leave town, and the community is left to kind of think about how it responds to what the inspectors have found. So communicating about the findings at the point at which, through press releases or whatever is one thing, but there are a bunch of people who are part of the system. There's the CQC, the CCGs, there's the local health watches, as well as the providers and the local authority, all of whom are still there. And it seems to me there's a question about how communications to the public are managed in the next period beyond the point at which you have the quality summit, and what the CQC local inspector role is in that, in kind of marshalling everyone to make sure the public know not just what you said when you were there, you left town, but what's actually happened subsequently and whether things are improving, and et cetera, et cetera.
A very brief response on standardisation, just to say that there are several different elements of standardisation. It's producing our guidance so that people are doing the same things. It's making sure that our inspection teams are properly trained. There is an element of the crossover of personnel doing more than one so that they can get that idea of, was Hospital A really different from Hospital B? But then just to assure you that we do have that final step of a National Quality Advisory Group, which is a pretty rigorous process for trying to say, are we being, have we got this right? Have we got the evidence to support this or that? And we're still learning on that. And on communications, of course, the CCGs, the Health Watch, social services are all at the Quality Summit, and they all have roles in helping us to promulgate whatever we've found.
Okay, Mike, thank you. Mike, thanks very much. Andrea?
Thank you very much. You've had the report, so I'm not going to kind of read it out word for word. You'll be pleased to hear, but just to draw out some of the key points. The first one is around priority number 1, which is developing the new regulatory approach, and I've mentioned it in the report, and as it's been kind of referred to in the discussion from Mike's report, I thought I would dwell upon the issue of consistency, because the same issue gets raised with us from a social care point of view, and as Paul quite rightly says, we're not talking about hundreds of organisations, we're talking thousands of organisations, and once you add together residential and domiciliary care, we're middle 25,000 really. So how we get to a situation where we can be confident about the judgments that we're making across all of those services, and understanding that the social care sector is incredibly heterogeneous. So there's lots of diversity within the sector, as well as kind of as managing the numbers. So we are looking at that in terms of being very clear about what the lines of inquiry are, the tools that we will provide for our inspectors to go out and do the inspections, using the insight that we can gain from the data that's available, but also from organisations like Local Health Watch and the local authorities about how we should be focusing those inspections, and also making sure that we've got a kind of quality assurance, quality control process through the management structure. And what will be particularly important is about ensuring that we're supporting our staff through the training and development that we do through the academy, to ensure that they know what good looks like, and
we can be assured that we're not making judgments on the basis of people's individual preferences as to how they think a service should be looked at. But the important thing for us, and the other point that I wanted to focus on under priority 1, is the first wave of our pilots, which will begin in April. And what we're doing at the moment is identifying the organisations that we want to include in wave 1. And to pick up the point that Kay asked, what are the services that we're going to be looking at in wave 1? So we reckon that we'll have nearly 270, which will represent about 1% of residential and domiciliary services and 10 hospices. But we will look across the service provision. So services for people with learning disabilities, mental health, older people, across the country and across the kind of different sizes. So, small and very local operations to some locations which would be part of the big corporate providers. So we've got people in the regions at the moment coming up with their potential list so that we can kind of make sure that we've got sufficient breadth in the types of services that we'll be looking at. Because we will actually be making quite a significant ask of the providers in this first wave, both in terms of testing out the information collection that we want to do in advance, and also in terms of the evaluation, which will be very rigorous through this process. We'll be asking them to agree to take part in that. But David and I met with a group of providers yesterday who were raising a whole set of issues around our current process, and we had people volunteering their services as they were walking out the door. So I'm very confident that we will get the numbers that we need in the first wave and the breadth as well. So undoubtedly we will come back to that in future meetings. Just wanted to highlight that we are progressing, as David mentioned in his report, to recruiting the Deputy Chief Inspectors for the Adult Social Care Directorate. But I would like to welcome the first appointment, which is Malcolm Bower-Brown, one of our existing regional directors, who will be one of our Deputy Chief Inspectors in my directorate from the 1st of April. And finally, on the building confidence side of things, trying to get out and about and talk to as many people as I possibly can in as many different circumstances as I possibly can, because actually learning from what we're doing now, what people think about it and how they want us to improve those processes for the future has been incredibly helpful in helping to shape what we're doing for the future. So that's been through the co-production group, and Kay very kindly joined us at the co-production meeting that we had just before Christmas, after the last meeting of the board, and it was a very rich and robust discussion. I think you probably agree, Kay, but it's been very helpful to have that input, and people have continued to contribute outside of those meetings as well. And I've highlighted some of the meetings with commissioners and with other national partners, but would also like to emphasise that I'm also getting out and about and meeting providers too. So mentioned the meeting that David and I had yesterday, but also going along and seeing individual services and observing inspections as well. So there's an awful lot of that sort of work that's going in to help make sure that how we're developing the new approach is responding to the issues that people have raised with us. Happy to take any questions.
Thanks, Andrea. Yeah. Jennifer.
Thank you. That's very nice and clear. Thanks. Just on the, I just wondered about your thoughts about where there are chains of providers who are national, and what our thinking is on assessing the well-ledness of those groups. So it's not an individual provider; it's actually a national chain.
Yes, thank you. That is one of the things that we're looking at in the well-led domain, and thinking about how we take into consideration what the infrastructure is around the service that we're looking at in terms of is a service well-led. And the other thing just to mention as well is that there are also some councils who have a number of services still, and I think we've got to think about those as well in terms of the corporate infrastructure supporting those individual locations. So one of the things that we have in existence at the moment is a corporate provider team that does quite a lot of work in analysing the activity of our corporate providers, and that team will sit within the Adult Social Care Directorate in the future. And what I want to make sure that we do with that is two things. One, create a much better and at a senior strategic level relationship with corporate providers, so that we're actually understanding what their strategic direction of travel is, and secondly, ensuring that that overall analysis of what's happening in corporate providers is part of the intelligent monitoring that goes into the data pack for inspections of locations. So trying to kind of bring the two things together.
Not really an issue yet for health, but it could be on the acute side.
Thanks. Two things. I was struck by the State of Care report and what it said about deaths in care homes, which identified turnover of staff as being a key association of what it referred to as death notifications in care homes, as opposed to understaffing. So lack of staff was not a predictor of deaths. Turnover was, and it drew the conclusion that organisations almost adapt to chronic understaffing, and people's roles absorb the problem. But when there is a rapid turnover, the organisational chaos that goes with that is destructive and difficult to compensate for. Now, I just mentioned that, I suppose, because I thought it was a very interesting thing, which got very little attention, actually, in amongst all the A&E focus that came with State of Care. But it also raises questions about getting key indicators and making sure that people have have the right information, they're able to measure, and based on what you've just said, Andrea, able to provide you with that information in a timely way. You need to know that kind of thing in advance, and I suppose in an honest way. It does also, for me, raise the issue of comparability that we were just talking about, because it may be that is not true in other settings. And so when we talk about standardisation, it is very important, I think, to get this difference between comparability and standardisation. And it may be that comparability across sectors is going to be more important than getting the right thing. If I just ask one second point, are you able to say just slightly more about what is likely to be one of the more difficult areas of your work, which is about home-based care, and what you're learning at the moment, which you'll be able to apply in home-based care, what the timetable might be, and some of the really difficult practical issues like getting testimony from individual clients and their carers.
Thank you very much. I can only agree with you about the kind of group of points that you were making around staffing. That is a very important aspect of what we need to be looking at, and we can see that in a variety of different ways. The Panacoa report that came out just before Christmas, looking at the prevention of abuse and neglect old people in institutional settings, which actually also included hospitals as well as care homes, drew an absolute link between how well staff were treated and the quality of care, and that equally can link to turnover, because people who are being supported, have their learning and development paid attention to, are much more likely to stay and kind of focus on providing good quality care. So we're very mindful of that, and very mindful that issues of staffing are things that we will need to be looking at and getting information about. You are absolutely right that home-based care is one of the kind of really knotty, wicked issues that we've got to address. And we're looking at a variety of different things to learn from what we're doing at the moment, and also to think about how we can share learning, particularly with the work that Steve is doing and Mike in community services. So in terms of learning at the moment, one of the things that we don't do quite so well at the moment is to get insight from people who are using services, because it is very difficult. And one of the things that we're looking at is actually thinking about what's the timetabling of the inspection process for community services, so that we're doing the pre-planning a much further in advance than we currently are, so that we're getting information about the people who are using those services, and so that we can proactively get insight from them, either through telephone service or whatever else, whatever other mechanism might be appropriate, so that the inspectors get that information before they start doing the inspection. Currently, it's not timely in that way. So that's one of the learnings that we've got that we're taking into the future. The other thing that I think it would be very useful for us to explore, and Steve and I have had conversations about this, is the Steve's looking at having listening events focused around the clinical commissioning group areas. And what I know from all of my experience of working with communities in various different ways is that if we bring together people to talk about the health services, sure as eggs are eggs, they'll start talking to you about everything else, including social care, and usually housing. But actually, we can make a virtue out of that by doing that jointly and using that insight that we get from those sorts of listening events. The timetabling of it, we've got to think about. There are logistics associated with that, but I think that we can actually do something quite powerful around taking that insight, as well as working with local Health Watch and others and local authorities to get their insights on it as well.
Thanks very quickly, please, Anna.
I'm sorry to be boring. I just want to go back to this issue of quality assurance again. And it's my recollection, but I just wanted to check this, that we asked in due course for a report on the plans for quality assurance. And I just wanted to sort of add to that request, if I'm remembering rightly, that when it comes back as a report on quality assurance and not a report on quality assurance in general practice and social care and hospitals, because I think there's something about in terms of the standardisation, comparability, and actually arguably in terms of the integration agenda, that actually we see this quality assurance process in the round and the way that it can contribute to all three.
I think the Kieran Walsh work that's being done with the King's Fund will be just around acute hospitals, because we're ahead of the game on acute hospitals. But I think maybe by October
Yeah, I think that's right. So when we will bring it back for all sectors, and as the principles, we will do this once, and that's partly right. It sits with me. And it'll need to be sensitive to the different ways and things which are produced. If we can do it before October, we will. It's certainly a kind of big part of the work that's ongoing in Mark Edmonds' area already.
We'll note it down. It needs to be done. Absolutely. We must be assured that we're getting consistency across the piece. Yeah.
We will need to think about then how that feeds through to give us as a board assurance. So there's a kind of direct link in governance terms and accountability between that process and our overview of all of this. So it's a very important element.
Andrew, thank you very much for that. Just in parentheses, really, Andrew and I met a family 3 weeks ago. I won't say any name, but they had a number of very disabled children, and they were totally dependent upon really good, high-quality home care to survive. And she said, the mother said, she had lived in fear for 26 years because she couldn't complain without fear of retribution. I mean, I think we were both very shocked by that, really, weren't we? And it really woke me up, just the importance of this whole domiciliary care patch. It's so important we do get it right. Steve.
Thank you, Chairman. The paper is, the update paper is self-explanatory, but again, I'll draw out a few issues. Just going back to quality assurance, of course, the sort of areas I'm responsible for are not just general medical practice, with its 8,000 or so sites, but 11,000 dental sites, prisons, secure environments, safeguarding, etc. So when we start to look at quality assurance across the 3 directorates, the individual services that I have some responsibility for look very different to, say, a hospital. So, for example, we will start to get our teeth into looking at 111 and remote services at some point in this year, and how we look at that from a judgment point of view will be different. But I think it is interesting how we can compare like with like, and as we move towards the autumn looking more collaborative and integrated services, clearly reports will cross the boundaries that we've got, and the handoff question earlier on was an excellent one, because handoffs in any service are where the problems happen. Drawing out a few points on here, my first deputy's just been appointed, Matthew Traynor, who's an exceptionally talented young man and currently the director for London, but he'll also be leading our work on integrated care, linking to Andrea and Mike, but specifically linking into Paul's directorate, so that we work very closely on themed reviews and integration together. I mean, so it's just great starting to get a team together. We currently stand at 3, of which all 3 are amazing people, very talented and great human beings as well. So I'm incredibly hopeful about taking this forward. The out of hours, GP out of hours, Wave 1 begins the last week of January. So a substantial amount of the work has been looking at how we look at information, data packs. We've held a 2-day training session for inspectors for out of hours, so that by the end of April we'll have visited all of the out of hours providers that haven't been inspected in the past. And then as we move into July, we start to work on the ones that have been visited, and then private providers. And this project will go on right until the end of the year. One of the problems we've discovered is that people, even though people register to be providers of out of hours, some out of hours is provided by people who haven't registered because of the anomalies in the system of some GPs taking on, carrying on with out of hours care. And our response when we wrote to the CCGs about who they commission was not very good, and therefore we're trying to clarify the data we've got at a very basic level and work closely with NHS England so that we're clear about who is commissioning and what they're commissioning. And for me that's really important, because back in 2010 with David Cointomi, I chaired for the previous government a review of out of hours in general practice that followed the Urbani case in Cambridge. And part of our review is a review of that ministerial review to ensure that with the, some would say, fragmentation of the NHS over the last couple of years, we're clear about who commissions services, what's happening to the performers list, as well as the actual provision. And, you know, I'm not prejudging anything, but the data issue has hit us right at the start and has been very challenging. So out of hours is taking up a lot of time. We're gearing up for Wave 1 general medical practice in April, and there's a paper later on the agenda about children and child safeguarding, which I'll speak to separately. But my final point, very briefly, is to say that given that general practice and out of hours has taken up such a lot of our time, we're now having more meetings about dentistry. We've met with the inspectorate from prisons. We're talking with Ofsted about children. We're having some very, very good meetings with the regulators in dentistry, and things are moving in a very positive way forward. Thank you.
John and Jennifer.
Can I just ask a quick question about out-of-hours services, which are, as you quite rightly say, varied across the country, and if there is a provider there, you can obviously inspect them. But if there isn't a provider, do you just regard that as a blank space on the map, or is there some cause for comment because there isn't a provider?
There is a provider. It's working out who and what they are. So
Sorry, in that case, can I ask a supplementary question?
Okay,
Is
yeah.
111 a provider?
Not of general medical out-of-hours services. It's a provider of information. And when we start to look at urgent care, clearly working very closely with Mike and Andrea, urgent care involves health social care, it involves remote information. It also involves NHS Choices and the website for providing information as well. One of the problems we've had is that we think some GPs are still doing general practice out of hours and are registered, but are then subcontracting in order to provide out of hours. In some areas we've had, well, in many areas we've no responses about who they are commissioning. And we're quite shocked actually at the paucity of information we've received so far, because that also helps. We need to plan, and we can plan against our own database of who's registered, but we'd like that confirmed by the CCGs, and we haven't got to that point yet. So that was a surprise. But what we want by the end of this exercise, which will be in the autumn, we'll give you an interim report in April, but by the autumn we want to know who are actually providing those services, and we can't tell you that at the moment, even though people have registered.
Sorry, just a quick comment on, I had to phone my GP surgery the other day. It's a really good practice. And the phone, the voicemail said, oh yes, if you're out of hours, just phone 111. And that was it. There was no explanation of what 111 is. And I thought to myself, if I was not a medic and I had a sick child, there's no way I'd probably want to go straight to rescue immediately, i.e. A&E. With no explanation. So there's something about what information is given. Well, anyway, so the question was more on the first 1,000 visits. If you could say to GP surgeries, if you could just give us some headlines about what the patterns are there, but also particularly the second related question is, how far are we on using the data from general practice, the computerised data? Are we going to, at some point in the future, get a kind of data dump from all practices? Because there's tons that we could be looking at that would obviate the need for certain lines of inquiry.
On data, you're on our list to talk to. This is in Paul's directorate, so we're being supported heavily by Emma and Paul's team, and the plan, there's a sort of working group, and they're working very hard looking at the outline data, working with NHS England at the moment, and we should in a fortnight have a sort of interim report about where we are with all of that. It's progressing well, but as you know, there's a lot of data, and it's how you use it. And in NHS England, they're also doing similar work, and clearly, if you were a member of the public, what you want is some clarity as well about what's being published, so you can understand it. With out of hours, we've started doing that work as well, and producing data packs, and of course, as wave one progresses on the GP out of hours, the information is so important. It's probably the most important thing that we do. As Mike said earlier on, it's the preparation before you inspect, which is key. The 1,000 visits we did talk about at the last board meeting. The current model is not fit for long-term use in inspecting, in that an inspector is trained, goes out on a visit, and doesn't normally have a clinical input from primary care. So what we're doing is what we are doing, which is you inspect what you can inspect. So you're looking at compliance across the regulations and the areas. Most of the first 1,000 visits, of which first visits come to about 950-ish, might be slightly 930, I can't remember the figures. We'll hit 1,000 new visits early in February. Most of those are targeted visits based on people either refusing to be registered, or tiny single numbers, or those who are declaring non-compliance. Increasing number but small number of whistleblowers or information from NHS England. A third, 34% overall, are non-compliant in one or more areas, but many of those are not serious areas. Of the random ones, it was 29% were non-compliant in 1 or 2. But that's a smaller number than the, but significant number. And of the ones we're very, very worried about, there were about 9 as of December. What you won't read in the press is necessarily is that CQC are removing registration and therefore a practice is ceasing to trade necessarily, because we've started doing this, NHS England are becoming much more proactive. And so we have examples in single figures of practices ceasing to trade with the lists being dispersed, but that's an action by NHS England with our support. And we're starting to look, as Mike has had to in more detail, at what the failure regime means for practices. And there is, we had a discussion yesterday around how you build up general practice in under-doctored areas, particularly if practices have been failing in the past. And alongside that, an issue of competition in general practice. If you're in a rural area and a patient has no choice in the past with a practice that might or might not be failing, or there might or might not be relationships, how does a patient, for example, in North Norfolk or in a rural area, get access to alternative care? And in the past, there's been an inconsistency of assessment of practices. And what we need is a consistency so that patients know what sort of services they deserve, and when they're not getting those services, why, and what the standard of that practice is.
Steve, you probably know this, but 1 in 250 men in England is in prison. And so their healthcare is quite a big part of of our responsibility. And I just want to ask you, because this is going to be a long-term plan to inspect the healthcare in prisons, but it does raise some quite important issues, one or two of which we've commented on already today. One is the comparability issue, because the commitment of the NHS is to provide the same standard of healthcare in prison as outside, and we're probably quite a long way from that in most prisons at the moment. Secondly, there's the question of how those services in prison link to services outside, because many people serve quite short sentences, and it's the continuity that counts. And then the third, and probably the most difficult bit, is how the inspecting health care relates to the issue of the healthy prison. Because one thing is how the clinics work in a prison, which you'll have seen, but there is a much broader question of the unhealthy environment, particularly the psychologically unhealthy environment. And historically, there's been this sense that the joint inspections with the prisons inspector have, they've not been an equal operation, that the health bit has been slightly tagged on. That's the impression. And so it would be very important to at least sort of make that equal, if not reverse it, so that we are looking at the health of the broader prison, not just healthcare as an isolated element.
I mean, you're so right, and we talked about all of those issues, as well as the issue which, as you know, drives me, which is about the inequalities agenda, particularly when you're moving into homelessness, and some prisons have a lot of gypsies and travellers as well, and so there's all those vulnerable groups. All of those issues were discussed with Nick Hardwick, the inspector for prisons, and it feels as though he's really committed to trying to improve in all of those domains. We have a very good team internally in CQC which will continue, and I want to appoint a clinical advisor with an expertise in prison healthcare, so that we can really sort of start to look at that. So the commitment is to work together, and the areas that you raised of concern he raised as well. So I mean, I think we're in a good place to move forward. And one of the areas talking with Paul as well is about the sort of themed reviews. So because we'll be going into each CCG area every 6 months, as Andrea rightly said, we will pick up the patient and public feedback with the hospitals and community and mental health trusts. But it means we can start to look at the themes of what about people who are bouncing in and out of prison, the continuity, The absence of handover. As a general practitioner, often I don't have a clue what's happened in the prison, and often it's vice versa when they're going from home into the prison. And that continuity of care with a unified record would be very, very useful. So I think we can really challenge all of the agencies that are providing the care, and I think we're in a really good place to do something special.
Just quickly, it seems to me the out-of-hours issue you were raising is if by April the whole effort of the CQC has not been able to track down who should be providing the services, we sort of need to publish that before we do the inspections, because that is a bit shocking. You know, there you are, a member public, finding it, but you know, if no one knows who's providing the services, that is really shocking.
That's right, and as you know, I won't hold back. And one reason for raising it today is that we're shocked so far at the information coming back to us. We do, of course, have a robust inverted commas, registration system. So we think we know, but it would be lovely that the commissioners could tell us who they're commissioning. And the handovers between, you know, as a patient in, I mean, Jennifer makes a fantastic point about, actually about just accessing GP surgeries. In central Birmingham, the Children's Hospital A&E department sees lots of children's emergencies. If we start to look at children's urgent care and join everything up, often patients tell me, even with our own surgery, that it's easier to take them down and be seen. And so the public of England deserve a joined-up system, and a better joined-up system than is there in many places. But we need the evidence to make those statements robust.
Steve, thanks very much for that. Moving on, Paul.
So this is the December Performance and Finance Report, and in the spirit of picking out the highlights rather than going through every part of the paper, we still remain on track to complete the overall inspection programme for this financial year by the first week of March. That's particularly important for us this year, so that with all the amount of conversion training that's going on and the shifts from generalist to specialist inspection, that we give ourselves as much space as we can at the end of the year to provide the training, and so that links in heavily with the academy work. I think it's also worth noting that the National Customer Services Centre is meeting its key metrics despite a significant increase in volume, which is a tribute to them, and they continue to rise up the ranks of quality as far as benchmarking with other customer service centres, private and public sector. Our Mental Health Act Commission inspections that we sometimes don't touch on as much as we should are also pretty much on track. We do 1,000 of those every year, and it's worth drawing board's attention to that. We've discussed in the last couple of board meetings the time it takes to issue a report against the standard of 25 days. And we've had discussions about how we bring that up sector by sector, and particularly the NHS trusts, that it tends to take longer. Although we're still not at our benchmark, overall there we are making significant improvements in the NHS reports. We're now at 57% within the 25-day timescale, so that's ahead of where we thought we would be able to get to by year end, and that's pleasing. In terms of the things which we know we still need to do better on, our registration, our commitment is to register people within 8 weeks, and similarly for variations registration, we want to be that, our standard is 90%, we're still only at 80%, but that reflects the fact that we're taking a more rigorous approach to registration. The transformation programme that Hilary leads continues to move apace, but the new approach work stream, which sets out our new regulatory model, we still rate as amber red because of the level of complexity and risk associated with that. But that's a conservative judgment of how hard it is, rather than that we're concerned per se. There are things that are deeply off track, but nonetheless we don't want to be complacent, so we rate that as amber red. And if I move to the finances towards the back of the PowerPoint report, we still have underspends for the year to 31st December, as the numbers show there. We think that will come down significantly as far as the full year projection goes, so that by the end of the year we are only 2.1 million off, if you like, on the revenue, or those 7.1 million off on the capital. I think the underlying point is that we will only spend money where we know it's going to add value. That's we're not going to spend it for its own sake, and we will complete the programme and do the work we need to do with the money we have available.
Thanks very much, Paul. John?
Got a very quick question, and that is on the complaints section. And this isn't about the detail of the complaints, by the way. It says that there will be a quarterly report coming to the board. I just wondered when the next quarterly report was going to come.
I'll find out. Claire says next month.
Next month.
I found it.
I've got a quick question. On enforcement, it's page 4 of the report, sort of locations with warning notices, and the graph is very erratic, and it sort of goes up and then down and then quickly up and down. I just wondered, what's behind that? Is it just complete randomness, or it just makes me think, well, what does that mean? To see that we've got such sort of sudden peaks and then it goes down. You might not know, but I just...
No, well, I think there's... I certainly don't know all the detail, but the two things. So some of the variation is seasonal, if there are fewer days in the sort of inspecting month. And particularly, I expected it to go down in December, so fewer working days, and it did. I think it is worth saying that the draft doesn't start at 0, so it really exacerbates the, if the kind of averages of sort of 60, 65, and it goes between 50 and 80 as a peak. There is some variation, but we're really exacerbating by only showing between 40 and 85 on the chart.
Thanks, Paul. We're going to, this pack is going to be thoroughly revised for next year, so just to preempt any questions on that score. Good. Thanks very much, Paul. Market oversight, Andrea.
Thank you very much. This is a joint paper from myself and Paul because the vast majority of the work that's happening at the moment is taking place with Paul's team in regulatory development and policy, but overseen through the governance structures with me. The board asked for an update on where we were with market oversight, taking into consideration that this is a new role for us, and I should preface everything that we say by reminding us that it's dependent on the passage of the care bill. So we don't actually have it yet, and it is subject to the will of Parliament that we get it. So so we're doing the preparation in advance of those decisions, but it's absolutely critical that we do, because although the powers won't come to us until April 2015, April in 2015 isn't actually that far away on the basis of the number of things that we need to do. You've had the report, so I won't go over it in detail, but I just wanted to highlight some points. The critical thing about this, and the reason why I personally think that the Care Quality Commission is the right body to be taking on this responsibility, is that this is all about protecting vulnerable people, and actually at the heart of it, it's about people, continuity of care, and supporting those people, so that if there is a significant market failure, they are looked after and they don't end up on the street. So the question is, how do we spot that happening? And if it does happen, how do we coordinate the response? There is market failure in individual circumstances in social care, which local authorities manage on a kind of regular basis at a small scale. But what we would be looking at is those providers who have coverage across England, where a failure of those services, actually it would be very difficult for individual local authorities to cover it. So we're looking at how do we get the early warning signals in place, and then how do we respond? And one of the other things that I think that I would like to emphasise is the early warning systems is about quality and finance, because actually quality will start going wrong before we start observing that the finances are looking shaky. And so I think that the integration of our insight into what's happening with some of these providers from a quality perspective, as well as working with them to understand the financial situation that they're in and whether that's going to lead to a problem or not, is integrated. And so the comments that you've made, David, about sort of those two things being together, I think are right. We're doing work internally to be clear about what's the information that we already have and the basis on which we can develop our role. We're very clear that there are new skills that we will need for the future, particularly in that sort of economic financial oversight. And so specifying what that role is and where we would be getting the additional support is a very important part of what we need to do. So the immediate priority, which is to get to an operating model, the first iteration of the operating model by March, will start to give us a really good insight into what it is that we need for us to be able to deliver on this function. The other thing to say is that it's very important that we're actually working with the sector to deliver on this, because actually corporate providers have an awful lot of this information already, and boards of those organisations are obviously looking at their business plans and their financial plans and how they're handling those. So I jointly chair a group with the Department of Health, which includes people from the industry, to look at, and the focus at the moment is to look at what the regulations, the draft regulations should say, which will obviously guide the work that we do. And the meetings that we've had, I'd have to say have been incredibly constructive, because none of this stuff is easy, but people have actually really worked with us very energetically to make that happen. You've got lots of detail in terms of various tables which set out the process that we've got in place at the moment, the various people who are involved in that, some of the timetables that are associated with that. This fits within a governance structure within CQC to make sure that we are delivering on all of those things. And as I've said at 4.3, or as we've said at 4.3, the immediate priorities are around getting that specialist resource in to help us, working with the department on the draft regulations, and getting the first iteration of the operating model, which we aim to do by March.
Thanks, Andrea. I guess I just could maybe kick it up with two questions. One is, are we going to come to a view about overall size, irrespective of the risk within a business? Are we going to come to a view that actually an organisation is just too big because the consequences of failure will be too difficult? And this is part of the Southern Cross question, that an organisation gets so big that if it does fail, even if it's not likely to fail, that risk is just something that we're not happy with. That was one question. The second question is the capital structure of some of these private equity-backed organisations is fantastically complex. They will have done a huge amount of modelling for it on different scenarios of occupancy and fee increases and all the rest of it. It's going to be very difficult for us to second-guess the modelling that they've done unless we have some general view that actually a very, too much leverage is a bad thing. I mean, so are we going to? Do you think we'll? I mean, it's early days, I know, but it seems to me it's a difficult judgment to make, I think.
You've identified some of the difficult questions. Thank you very much, David. And I don't think I've got the absolute answers to those at the moment, because we are still doing the work, and it's important that we don't prejudge that in terms of making what would be, from my point of view, ill-informed judgments about what those things would be. So I don't want to kid you on that. Paul might have a cleverer answer because he's cleverer than me, but on size. I think that there's an issue about we have market oversight, we don't have market shaping as a responsibility. But I think that we will be getting ourselves into a position where we have a much better understanding of what the market looks like and the inherent risks to the sizes of organisations and the the breadth of those organisations, because one of my other concerns is people might expand, but they expand in a way that they go beyond their capability in terms of the services that they're really good at, and going into areas where they're not necessarily so good at it, but it sort of looks like it all fits, and so people expand, and then the whole thing falls over because they've overstretched themselves, and we've seen examples of that in other sectors as well. So I think you're right, it is an utterly complex set of questions, and I think that we have to be careful about making our judgments on the basis of evidence that we bring together. But Paul, I think you might be able to help me out.
Yeah, no pressure there. So I think the starting question isn't whether it fails or not. The starting question is how do we ensure continuity of services for the people who are living in the homes. It's better if it doesn't fail, but the absolute key thing is the continuity of services. I think on the absolute size, I think as a starting point, it'd be the concentration in the geography or the concentration of the service type that would be at least as important as just the overall size. And although there are some big corporate providers, we'll do the numbers on that. It's not a particularly concentrated marketplace. It isn't the case as one provider with 40% of the market or anything close to it. And I think on your point about the metric, because the complexity of the financial structures lying behind them, I think we have to have some pretty basic ratios that we look at. If we don't, we're sunk before we start. And if leverage is above a certain level, then we're going to have to take a more active interest.
So on size, I think it's a really important question, and we do need to bottom it and bring something back to the board. One of my reflections, though, is if you get a big one that's okay, and it takes over a medium size or a small one which is failing, it doesn't add up to a good big one. And therefore, I think we need to take a view on the quality of what's there and the robustness and the resilience of that which is taking over the other one to actually make those improvements within a time. And it's not a million miles away from the regime around hospitals, which is how long, if a big hospital takes over a failing hospital service, have they got to turn that around, which is a hot issue just at the minute. And I think there are similar issues of where a big care group takes over a smaller care group which is seen to be failing. We need to satisfy ourselves about the resilience of the one that's taking it over to actually move the poor one to the standards that need to be achieved within a given period of time. So I think there is that. On the Southern Cross, I know from my last job that OFT set monopoly at 40% of all provision. And there were one or two places in the northeast of England where Southern Cross, as was then, had over 30% of the provision in one or two local authority areas. I would not like to be a director of social services that just saw 30% of the beds go overnight. That would be a big issue about resilience and continuity of care. And any resilience plan that people had, care home goes down because of the floods. Is really under trouble. Is really under some kind of pressure. So I think these are issues that, as we do this work, David, we need to take a view on, as well as the point that you've made about leverage and over leverage, because people still are borrowing money to actually expand, and there is new building going on in care homes. So there is money coming into the system, and that's all money that will have to be paid back somewhere on a business model which is under pressure. So I think these are really, really important questions.
And I think the last thing is whether we need to think about outsourcing some of this work, where, I'm not sure we have internally the kind of financial people who can provide the kind of assurance that we need, but that's something else to just leave with you, I think.
Absolutely, and I think that's kind of the next stage on from getting the operating model, which actually will help us to identify what are the specific skills. And I think you're right, David. There are particular aspects of that we won't have internally, maybe better provided to us from an outsourced organisation where they kind of have skills and they have the kind of backup. There are other things that we do have in terms of some of the basic analysis work in terms of activity, which we can have internally, but we need to balance those things out.
Sorry, just a quick question. OFT and the Competition Commission aren't mentioned here, but I presume you're completely involving them because it's very relevant to particularly a national response with respect to substantial lessening of competition and consumer benefit.
Andrew, thank you very much. Will you just keep us up to date as we go forward? Sorry, Anna, did you?
Oh, I was only just going to say that in terms of outsourcing, I mean, Monitor must have some of these skill sets in spades. You made the point about sort of relationship between the hospital regime and some of this not being entirely different. I just wonder whether we're begging, borrowing and stealing some resource to help us think this through from Monitor now and possibly in the future.
So I think Monitor do have some of it, so some of the sort of financial modelling. Whether they've actually got the detail on the sort of complex financial structures, maybe less so because it tends not to be so much for FTs. But I knew that they outsource a lot of their work anyway to, for example, the accounting firms, and we can certainly ask them how they sort of think about that. But we also want to reach out to people like the HCA and the Financial Conduct Authority.
Okay. Thank you. Steve, Safeguarding Children.
Thank you, and thank you for taking the paper on the public part of the board. This paper is about safeguarding children, and the reason the paper's come here is that this is a really key activity for CQC. We are the regulator for health services provided for children. That does include healthcare in hospitals, community homes, schools, both in the NHS and in independent sector. And the key theme coming through this paper is one of the need to look at integrated services. And if you go back to Victoria Climbier, whose report I carried around in my bag for a long, long time, and it had a profound effect on me as a GP. This is something we can really build on a very good team within CQC and do even better as we start to look at a more integrated approach. So what we're seeking is support for a proactive way forward. The history of why we're here is in the document. We've met with Ofsted, who have decided to defer their multi-agency work for another couple of years because they were just getting their service in tip-top condition so that we can then start to work more jointly together, and it's a very positive response to work with us. We have a small team now already in CQC, and this paper is written by Sue McMillan, who's been pulling all of that work together. The proposal is to join things up at a local level, with the local unit being the CCG, which builds into local authority areas, and build, as we discussed earlier on the information people will get from the public, the community, from health and social care, from schools, etc. The way forward is that we wish to start to look in every area across the country and build on these integrated visits, so that Ofsted will join us in due course. But this paper shouldn't be seen in isolation of the work that we're doing, particularly in Mike's area with children, and needs to be joined together. The paper's there for people to read. I won't highlight any other area and leave it for questions if people would like to ask questions.
I'd just like to reassure everybody that particularly in the community programme, safeguarding is a very important component of that, and in our first developmental inspection yesterday we had a very good interview with the person in charge of safeguarding at the community trust, and I'll report back to you on that.
Yeah, thank you.
So there's safeguarding, and then there's inspecting children's health services. Is this both, or is it with a particular emphasis on safeguarding? You know, because there's a difference, isn't quite a big difference. I mean, there's an overlap, but there's also
very big overlap. This is the team which is focused on child safeguarding across our different directorates. The inspection of the services, most children's care actually happens in primary care. Important children's care happens in hospitals and other areas. And Paul, with his themed review hat on, is just finalising some work on the transition between children, adolescent, adult, which, as we said earlier on, handovers in any service is a real problem. But if we're inspecting GP surgeries, we expect all staff to be trained in child safeguarding, to understand the policy. And it's a multi-agency issue, and the same, as Mike says, in community services and indeed in hospitals. One of the reasons for bringing this paper, which I think the paper's really, has been written by Sue, is really, really well written, is just to indicate to the board and to the public outside how seriously we take children's services and children's safeguarding as an organisation.
Definitely echo what Steve says, and it's covering safeguarding, but also the healthcare of children who are looked after. I think what we, in addition to giving the update on the work that we're doing, we really just want to get the board's views on. We have a range of different activities that are now happening around children, as Mike sort of alluded to, essentially in all the different directorates, and we know that we could either do those things largely in isolation and try and learn the lessons, or we could do them largely in isolation and then actively sort of work on, so what do we know per locality. But what we're suggesting is we don't do either of those. We instead up front say, right, what is our plan going forward in this area, local authority or CCG? What is the set of activity we expect to be doing in community services or child and adolescent mental health services or primary care, in addition to the specific work on looked after children and child safeguarding, and coordinate it up front, so we've got the best possible chance of understanding for those two particular groups of kids the quality of the services, and making a judgment on that we could potentially report on. We're not claiming for a second to have all those plans locked down what it would look like, but it's a steer on whether that proactive approach is a better one than reactive, or just try as you go.
Well, the way you've written the three options, I mean, no one's going to come up with anything else but the third one. I mean, does anyone in favour of the reactive option or no action?
Just a comment and then a question. So, I mean, on the face of it, and perhaps it's the persuasive language, but I mean, it makes sense to me because it's more. It is more about the whole system, and this is clearly a whole system issue rather than a kind of different sectors of the system. So, intuitively, it absolutely makes sense. But if I recall rightly, when we previously talked about our work in this area, Camilla was particularly concerned about the way that we were doing it, and I'm just wondering, and she's not here now, and I would have liked to hear what she had to say about it. So my question is, have you talked to her about this, and is she what she said in this area?
No, we haven't, but I caught up with Sue yesterday and suggested that she speak to Camilla after this meeting.
I just would be reassured if she felt more comfortable with this too, but I personally do.
So sorry, just to say that this is clearly a really important area, and if in the spirit of constructive contributions, I think that this paper for me was not clear actually, and I had to read it several times to really get to the bottom of it, and actually now I understand it because of what Paul has had to say, I think it's such a critical area given what's happened in the past, that if there's some way we can return to this and just have maybe a presentation or something about really what's happening and what our thinking is, I think that would be really helpful. I'm sorry if I'm the only one who found that, but I have to report that.
It's important you do, Jennifer. Thanks for that. Lewis?
It's a very specific question. We're talking about looked after children, but are we talking about looked after children after they were looked after as well? Because that is one of the critical issues for service integration. In other words, these are people who are often abandoned by the system once they've left the institution where they've been.
Yeah, I mean, from a safeguarding point of view, there's a massive primary and local, primary care local authority area there. This is to try and join up the service. I mean, to answer Jennifer's question as well, this is a paper which sets the direction, particularly as we're reorganising CQC and the roles that people have and the management line accountability. And what we wanted to do through this is to indicate that we will join and work with other agencies and across CQC. And I do think we need to bring something back when we're up and running in the new system. But the answer to your question would be yes, because this is about children generally.
But go on, David.
It's a really important question because the government has just announced they're going to extend the responsibilities of local authorities for children formerly looked after to 25, I think. And I'm just racking my brains. Local authorities do have responsibilities to children up to the age of 21. I thought PCTs did. What I'm not absolutely clear about is whether that's been rolled across to CCGs. So what we need to do, I think, as we come back, as Jennifer suggested, with a kind of workshop or a seminar or something, pick up that point. I think they do, Lewis. It's my answer to your question, but I just want to check the law as it relates now and the transfer of responsibilities. But the Children Act puts specific responsibilities on health organisations to meet the healthcare needs of children looked after. From memory, I thought that included care leavers, as they were called, and I think the government's extension of this to 25, which they announced just before Christmas, my sense is probably covers this. But let's not do this on memory, let's do it on facts and build it into a seminar.
From my own point of view, this falls into the really important bracket about which I know very little, I have to admit. This is not an area I know enough about. So I think from my point of view, having a workshop outside the board, and not everyone has to attend it or anything, but I think it will be really helpful, Steve, because the falling between cracks bit that Camilla raised last time, and I think the point that you made, Jennifer, rather reflects my view. I don't really understand it well enough to really understand where the risks lie. So maybe we could set up a meeting outside the board, could we, for people who'd like to come to it? That'd be all right. Good, thank you. David, the framework agreement.
Yes, thanks, Chair. So this has been a report which has been in gestation for some considerable time, since 2011, I think, and it really is driven by the Treasury and Permanent Secretary in DH wanting to get some uniform structure around the relationship that DH enjoys with arm's length bodies. I do believe other government departments are trying to do the same with their arm's length bodies on a structure as well. So this is there's a degree of uniformity about this document. It's at one level, David, I think it's quite a clunky document in the way that it's written because it's following a kind of pro forma. My recommendation to the board is that it will be helpful for this to be agreed. I don't see this as a document that I'll be constantly pulling out of my drawer to work out what we're going to do, but it does try and get through what's the principal accounting officer's responsibility, what's the board's responsibility, what's yours as chair, what's mine as accounting officer, and how do they come together in a way. And whilst I think the language is clunky, its ambition just to sort out that line of accountability is what it's trying to do. So I think this is a necessary document rather than a hugely important document that I say I'm going to navigate this on, navigate our relationship with DH on. So I'm happy to go into detail. Alistair, who's done every yard of this since 2011, I think, in the various iterations, is in the seats at the back of the room. But my recommendation is actually let's just see this as a necessary bit of the architecture between ourselves and DH. I don't think we give anything away, neither does I think it particularly helps me to do my job, neither. It probably helps people to take exception to what I've done rather than help me to do the job. But I offer it to you in a spirit of treat it as necessary stuff rather than the most important thing. But I would not wish to fetter your non-executive director responsibilities to challenge me on this. Thanks.
Alan?
I was just going to say that I think actually Health Watch have been part of the problem, because we at various times put spokes in the wheel. So, but that was because although it is a document for the record, it was really important that to us that it reflected the nature of the relationship between CQC and Healthwatch, which is only a small part of this document, but for us a very important part, which I think it now does. So I was just going to say thanks to David and the team for their forbearance, because it's been a minor detail to CQC, but an important one for us, and I think we're now very comfortable it's been to our committee.
I think the only issue I'd make is that I don't want to miss a chance for just again reiterating the degree of independence that we have, you know, that we need to have to do our job properly, independence of the politics and the system and all the rest of it, and whether or not that does this adequately, or whether it matters whether it does it in here, I'm be guided by you, David, really.
I think it's really. I think John might want to come in on this. I think it's so this doesn't take on board the changes which the Care Bill will introduce, which do that. And you just get into this. Look, we'll never get this bloody thing agreed. Pardon my language. We'll never get this thing agreed because there'll always be something else that we're just reaching for. So it will need changing in light of the Care Bill, but I think what we do is probably we drop amended sections in consistent with the passage of the Care Bill and its royal assent, rather than just keep holding this for a time that's coming. And I think it's the Care Bill which will give that legislative statement of our independence that will come through. But it's an absolutely appropriate issue for us to raise, David, and I see this as a technical document rather than but if we want to view it as a symbolic document, then you can escalate it to a higher form, and one would argue then, if we saw it as hugely symbolic, more work needs to be done on it. My recommendation is take it as a technical document that will be constantly evolving, rather than we're looking for the Versailles Treaty or something.
Okay, there are three comments, I think. John
David,
first.
can I just come in quickly first to say thank you for raising the point which I was going to raise, which is my concern about it. I think David's suggestion is a very elegant one, that we should agree it. But I'd like just to take it a little bit further, which is to say that I think we should agree it and have on the stocks our proposed amendment to the paper when the Care Bill becomes an act, so that rather than for waiting for it somehow to to evolve itself, we actually have we have a proposal for amendment when the situation arises, rather than hoping for the best. My only other point is I was just intrigued that there isn't one of the rather boring detailed changes is actually in the structure of internal audit, which is now provided by, as a result of Treasury decisions, is now going to be provided by the Department of Health to the CQC and other arm's length bodies, and I would have thought that was something that they ought to be including at some point in the process.
Okay. Jennifer?
Yeah, thanks. I think we should agree it. And but the only thing I thought was that it seemed to be, to me, a little light on social care side of things. And in particular, if we really are getting into thinking about commissioning social care more, and indeed thinking about a market mounting a national response in the case of a failure, I just wondered whether there was enough in here that covers us and who we discuss, because it's very health DHE oriented. That was just my only thought. Maybe not for tweaking now, but maybe to think about if necessary, if we haven't already done so.
Thanks, Jennifer. Lewis?
I agree. I think we should go along with what David's suggesting. It just, let's not lose the point that you're making, I think, David, about the spelling out this issue of independence in more detail. It's very important to our public position that that's clear. And at the moment, I understand that the Care Bill isn't yet through. I've got message, but on the other hand, at the moment, in paragraph 3.6 of the accompanying note, there is a set of references to what changes are expected, and I'm sorry I forgot to check what sections 48, 54 and 57 of the existing legislation are, so I'm now not as informed as I intended to be, but I think it does need to be described in something other than those legalistic terms. It would help me greatly to know in practice what will this move to independence mean, and what does it leave behind, because there's a reference in the same paragraph to the fact that the changes will not exempt the Commission from other cross-government constraints. And it mentions political campaigning, but I guess there are other constraints as well that we might want to be aware of. And just setting out what new independence we've got in practice, what it actually means, I think will be quite important to how we present ourselves publicly.
Well, perhaps can we then go ahead and let David, he obviously wants to get this off his bloody desk, because I can totally understand, but with a covering letter, just highlighting the points that have been made. Would that be all right for people? Andrea?
Could I just make one tiny suggestion, which is on 4.6, and I know it says it's not an exhaustive list in terms of the things that we do, but we don't mention the deprivation of liberty safeguards report that we do on an annual basis. And I just think there's, kind of picking up Jennifer's point about balance, there's that would be an important one for us to include if we could possibly squeeze it in at this stage.
Okay.
I apologise.
Well, I think there's 2 points there. Jennifer's point and Andrew's point, and the more general point about independence.
Yeah, and I think combining Jennifer's and Lewis's is a bit of the way to do that, so a much more explicit statement of what this is about, and I think that will pick up the cable. Just on the independence point, David, just for members of the board, I think what the sum total of that legislation does, Lewis, is on all operational decision-making, we are sovereign. They are our decisions, and in the methodologies we use, they are now with us, and we don't have to ask permission to do any special studies or thematic reviews, which is what we previously did, which comes back to that operational decision making. So it's that's what the sum total of those clauses add up to. Although there's some deletions in there, or it removes things that we previously had to ask for. That's effectively what it does. So I think it's a strong statement of our operational responsibility. It effectively says ratings on our head, reports and quality control, quality assurance on our head. Where we go, when we go, how we go, that's our decision. So I think it gives us that operation in a pretty unambiguous way, quite frankly. We still get granting aid, so there's still that accountability to the Health Select Committee for the money we get, potentially to the Public Accounts Committee at different times. So I don't think it scrambles any of those responsibilities, but it does give a clear, much clearer statement of we're not asking permission to do the job we've been set up by Parliament to do. We are responsible for doing that and need to demonstrate it. So that's how I interpret it in my own mind. And if I was in front of staff, that's exactly how I would explain it to them.
Well, I think we want to put that in the when we write back to them with this. We should set that out. I think. Good. Andrea. Oh, so you're scratching your nose. Could anyone who's come to the meeting like to sort of add anything, make a point? Yeah.
Thank you, Chairman. A couple of quick points, if I may. One is in connection with the children and adolescent mental health services. In connection with children and adolescent mental health services, are they inspected, and by whom are they inspected? As I understand, the service is really rather variable across the country.
Thank you for that. Yes, they will be inspected as part of the new mental health inspection programme, and we have defined them as one of the core services that we will always look at in mental health.
Thank you. And finally, I wondered if the board would agree to including questions from members of the public in their minutes.
Yeah, I think you raised this with Claire, didn't you? And I think that the meeting sort of comes to an end, and then we have. But I think there's no harm in doing that. If you'd like your question to be recorded, I think we're very happy to do that. Yeah. Good. Thank you very much. Anyone else? No.
Thank you, Chair. This is to do with the information in the public domain. If I may bring to your notice that BBC have put up a website where all the A&E in the hospitals in your locality, all you do is you put in your postcode and up comes the information about your local hospital, A&E, data, what kind of service they are providing, how many people attending and what kind of care they're getting. The question I'm bringing up is because when there is inspection of NHS hospital trust by CQC, can you put some information on your website so that one can look up how is that, say, particular hospital? I come from Camden, and there are so many high-profile hospitals in Camden that if one wants to look it up, one can see what CQC thinks about the hospital. And secondly, I am from Health Watch Camden. I'm a volunteer there. And before I was with the PPIH and Camden Link. Thank you very much.
No, thank you very much. I mean, when we do an inspection, it should go straight onto our website, and everyone should be able to access it straight away.
The point may be, certainly with Ofsted inspections, you put in your postcode and you get everything in your locality. And it seems to me that's the point that's being made. It's the ease of access around where you live. And in a sense, as our inspections go in, they need to go in that way of retrieval, as well as a list of, as well as a list.
Paul, do you want?
Can we take that one away? Because I think we can certainly do that, and we improve the search function on the website. But I wonder if we can also reference the NHS Choices data for that locality when we publish a new report, so it's not just our views that you can see for the services in Camden, but you can also more widely link to the performance data, for example, for those services. Although the BBC covers the A&E work, all the other data as well is more broadly held on Choices, I believe.
I'm not sure that really answers your question. You just want to. I think the line behind your question is you want to be able to get easy access to information about your health services in your geographical area, and you're just really, I think, raising with us, could we make it easier, more accessible to people? And I think can we take that away and look at our website and see if we can't make it easier to use? Is that the?
Thank you. The reason I brought up this question is because, for example, there is for me, requirement to visit, enter and view some site or something, and I want to find out what CQC's inspection in that particular point, what happened, what they discovered, and then I will get a kind of background to seeing or a comparison, for example, to see what I'm looking at and what I should be observing or things like that. It's just for general instruction.
No, it's a good point. And can we take it away and we'll try and improve matters so that you can do that.
Thank you.
Sorry, I was just going to observe, so just from a Health Watch perspective, that one of the things that I think we are definitely saying to local Health Watch is that it's really important that you're directly and locally in touch with CQC inspectors. So I don't think you actually have to depend on information. I mean, the information on on the CQC website should, of course, be fit for purpose, but actually I hope you would feel that you could, that Health Watch Camden could be directly in touch with the local CQC inspectors and have that conversation before you decide to go and do enter and view. And I would definitely encourage you to do that from a sort of Health Watch England perspective as well as a CQC perspective. It should be a closer engagement than just dependence on a website, I would hope.
Yeah. Good. Thank you all very much. We could break for 10 minutes of coffee. Thank you.